Again, do you want me to change it? Because there will be a lot of slides I would like you to skip.
I'll skip.
Acute coronary syndromes, I'll try to be as brief as possible. We are quite late. There are three types: ST elevation MI, non-ST elevation MI, and unstable angina. How do you differentiate the three? ST elevation is quite obvious on the ECG. No ST elevation or even ST depression on the ECG with positive biomarker in the form of troponin or CPK or MB rise with classical chest pain. WHO classification of acute coronary syndrome, classical chest pain, biomarker rise, and ECG series. 2 out of 3, if you have, it is acute coronary syndrome. Unstable angina, if there is classical chest pain, no ECG change, plus or minus troponin rise. And if you see the hospital admissions, one half of acute coronary syndrome is due to non-diagnostic ECG. So classical chest pain with troponin rise, because if you leave them at this stage, they can progress on to ST elevation MI and the mortality is much higher. Next. So very bit of facts of ACS, all of us come across acute coronary syndrome at some stage. 30% present with a lethal arrhythmia, out of hospital cardiac arrest. 1 in 300 will fibrillate in the ambulance or in the pre-hospital stage. More than 50% of patients do not reach the hospital in ambulance. This is true of the Western world. We'll see what is true of this country. The average delay from classical symptom to calling an ambulance or seeking medical advice is 2 hours in the Western world, not in this country. We have known and understood coronary artery disease and acute coronary syndrome for more than 50 years. Plenty of new therapies, new advances have come in. A lot of new ways to diagnose. The mortality has started coming down, but it's not zero. Still we lose quite a lot of patients, probably out of hospital. Next. If you see the mortality from acute coronary syndrome from major trials published in the BMJ about a decade ago, the highest is with ST elevation MI. That much is the diagnostic value of that single 12-lead ECG. It's very easy for any of us to make out ST elevation on the ECG. The moment we have ST elevation MI, all of us are jittery because we need to treat it with right earnest. Non-diagnostic ECG, sometimes you have heard in your practice, patient was sent to the hospital, ECG was okay, some duty doctor said go home, patient dropped down dead. It happens all the time because it was that non-diagnostic ECG, we think it's unstable angina, you go home, chill off, see tomorrow morning, no. Classical chest pain, that is why is indicated as one of the inclusion criteria for diagnosis of acute coronary syndrome. Next. So the pathophysiology has remained unchanged. It is due to plaque rupture and an occlusive thrombus. When it is subocclusive, it causes unstable angina. Total occlusion causes acute MI. You will have a cutoff. Please go back. That white radiolucent thing is the thrombus. Coronary artery should opacify like this, and it would block. That arrow shows total block. Thrombus in the coronary artery is the pain as far as interventional cardiology is concerned. Very hard to handle the thrombus. Next. Time is muscle. The moment we lose 4 hours after onset of classical chest pain, we have lost a lot of muscle. We have lost the muscle. 8% loss in LV muscle is enough to cause all trouble. 25% to cause acute LVF, 40% to cause cardiogenic shock. Highest muscle loss is anti-wall MI. So it's very important that these patients are picked up early in our practice, and that's why we have that time limit for fibrinolytic therapy or thrombolytic therapy. We need to salvage that myocardium. Next. So it's very important that these patients are picked up early so that we can give them optimal reperfusion therapy, because time is muscle. Early and prompt restoration of coronary blood flow, the so-called TIMI-3 flow, prevents death. There's no question about it. That death is immediate and sustained. Sustained restoration of that flow leads to no reinfarction and effective treatment of recurrent ischemia. Next. Most important factor in management of ST elevation MI is the ischemic time from classical chest pain onset. Next. Every 30-minute delay leads to a 7.5 times increased risk of mortality, not immediate, sustained at 1 year. How does it do? It can lead to sudden cardiac death due to sudden onset of arrhythmia, or it could be progressive pump failure in the form of recurrent heart failure admissions. Next. Another thing which we see quite commonly is level of troponin rise. When the troponin is less elevated, mortality at 1.5 months is less. When it is 9 nanogram per milliliter at presentation, that high is the mortality. So classical ECG change with troponin rise more than 9 nanogram per milliliter, we are looking at that high mortality at 1 month. So we have to be prompt and restore the blood flow. Next. A lot of scoring systems, I will not go into this. This is all clinical. This is what we use in risk stratification of the patient. We look at the Killip class, blood pressure, heart rate, age at presentation. If you know the underlying creatinine, was there a cardiac arrest at admission? Was the ST segment elevated or depressed? Elevation of cardiac enzyme, and then give a total point. Total point more than 140, very high risk score. Next. Please go forward. That's the high risk, more than 140. Forward, please. Quickly jump. Yeah. So important because this scoring system predicts mortality. Whenever the gray score is more than 140, after we see all those risk factors, if you don't do a PCI for prompt restoration of blood flow, because nothing will restore the blood flow as promptly as a percutaneous coronary intervention. No thrombolytic therapy will achieve that patency in the artery as effectively, as rapidly, as quickly as a PCI. That's why we keep pushing about PCI, because failure to do that PCI with a great